So our interview today is with Dr. Jill Elwing. Dr. Elwing is a graduate of the University of Missouri who trained in internal medicine and gastroenterology at Washington University. She's currently a staff gastroenterologist at the St. Louis VA. Could you tell us a little bit about, your current practice and what you do and so on?
Sure. So I've been at the VA now about 11 years. And the nice thing is I have a pretty good mix of things that I do here. I've built up a good clinical practice with a diverse group of GI patients, ranging from IBD to IBS to liver patients. In addition, my clinical practice also is teaching GI fellows endoscopy, rotating on the inpatient service with them. And then in addition to the clinical practice, I also have the opportunity to do clinical research. I'm involved in one of the large cooperative studies that's looking at colon cancer incidence or mortality through either colonoscopy or FIT testing, and that's been a really great experience. And then a few other smaller research projects. And I have time to do also internal medicine teaching, where I rotate still on the internal medicine wards with the house staff from Washington University. So it's turned out to be a really diverse opportunity, and that's one of the things that I like about gastroenterology is you don't really ever get bored because you keep moving to new things all the time.
You were in private practice for a while after fellowship and came to the VA. Could you say something about your time in private practice and how you decided to come here?
Sure. So I worked at Mercy for 4 years, and that was actually a really great experience too. Really transitioned from fellowship to a very, very busy private practice where I think I really learned how to scope and scope well and learned how to troubleshoot things on my own. And I enjoyed that. I felt like it was definitely rewarding. But the model of our private practice was shifting more from an independent model to more of a model that was owned by the hospitals. And so our group was going through a little bit of change. And Brian DeGraff, who is now my chief of GI here at the VA, met with me and said, maybe someday you would like to shift back more into an academic role. And I was able to move back to the VA, and that allowed me to have a little bit more of a diverse practice with more of an academic feel to it and a teaching component. And I think that has really brought me to enjoy my job a lot more. I enjoyed the private practice part and I worked really hard and I think I learned a lot, but I think the opportunities at the VA with the academic component and the teaching component have been extremely fulfilling.
So tell us a little bit about how you ended up being a gastroenterologist. What led you to that? I think you've got a sister who's a pulmonologist, isn't that right?
That is correct. And a radiologist, but anyway.
Oh, I didn't know about the radiologist. Where's she?
Columbia, Missouri.
Ah,
She actually taught my medical school. They had a diagnostic class and there was a radiology section, and she taught my section on radiology. But so she's old, and I have 5 older sisters, so there's a little time between all of us. But I'm highly influenced by other people, I think, because Ray Klaus was just a great mentor, and I think he just made me fall in love with gastroenterology because he's just was a great person, and I loved his approach, and I don't know, it just made me feel like I belonged in that specialty. So I'm more or less influenced by my mentors, I would say. I also really liked the fact that you were, again, doing different things, because I easily get sort of bored, and I like the newness of everything you do in GI. You move from the clinic to endoscopy and just constantly doing different things. So it's just, I feel like it was meant for my brain to be continuously challenged and doing new things. And I think that's what kind of brought me to gastroenterology.
what's a typical day like for you? What do you do on a typical day?
So we sort of have this schedule that we follow, and for us, it's a couple days of endoscopy, and then there's always the clinic days. But if I had, like, for example, today I got here and I have been just going through taking care of just bread and butter gastroenterology patients, and some of them with IBD and some of them with IBS. But today was more of just a very intense um, clinical day. But a day for, like, yesterday, I got here and we did multiple endoscopies, and they were done either with the assistance of a fellow or in conjunction with a fellow. And in the meantime, I'm still answering patient phone calls and looking over tests, and trying to do the administrative stuff in between um, cases. But a day usually will be a lot of patient interaction, and then also some administrative information in between. Um, and then there are days too to focus on research, because I actually did also, right before this, I finished a publication committee conversation with my for my VA research, and was able to fit in a little bit of research in the day too.
Good, good. So the
Yeah.
publication committee for the confirmed study?
Yes, and that is still, we're still years away, and it seems like they're still holding on to that data very tightly. So, but I think the baseline paper is going to be published, and at least we're at least moving somewhat closer to getting some of that information out.
Oh, that's great. Is it,
Yeah.
so as a member of the publication committee, does that mean your name will be on the paper?
So what we do is we're vetting all the different ones that come through, and anyone who wants to be on a paper and wants to be a participant can, but we kind of are the gateway to make sure that the ideas are actually somewhat sound, and then try to put those into some sort of working order when the data is released to be looked at.
Maybe you say something a little bit about, comparing work-life balance between your two different jobs, being at the VA and being in
Sure.
private practice.
So, I think this job in particular has been really, it has afforded me the ability to do a lot of things that, specifically being able to work with fellows, being able to, like, have a very very varied career path. Along with that, because there's a lot of overlap, you have trainees, you have other physicians that you're partnering with, it also allows you to have a better work-life balance. So your child gets sick, there's someone that will cover for you. You have a concert you want to go to, you can find someone to, make sure that you can get to those things. Whereas when you're working in private practice and you're a one-man show, and those are your patients, and you are, don't really have anyone necessarily to fill in for you, there's a bit of anxiety that goes along with that. And I think especially when I first started in private practice, my child was only a couple years old. And so this has really allowed me to still be able to be extremely dedicated to my career, but also be very dedicated to my family. And I think that has been one of the biggest gifts, is just to not have that sense of, like, urgency and anxiety that sometimes I would feel in more my private practice life.
Do you think there's less of a chance of burnout as a result of this?
Yeah, I definitely do. Because I think sometimes I would start to see that, like, 3 or 4 o'clock time, and I would start to think about getting to, like, the daycare to pick up my kid. And it would just, start kind of bubbling up inside of me, this anxiety, and I could just feel it every day. And when you have that kind of pressure, you do lose a lot of the enjoyment. It's just like a negative on your brain. And then there's a certain level of burnout that comes along with that. So when you have that feeling, even if you're at work the same number of hours, if you're not feeling that sense that there's always that push or anxiety at the end of the day where you can just enjoy your work, I think that is a lot more satisfying.
Is there a financial trade-off? I mean, I assume that you probably got paid more in
Yeah,
private practice.
yeah. I mean, I I feel like I'm extremely satisfied with what I'm making. I feel like what I'm doing and I'm making is great. And the benefits at the sometimes people don't realize, but there are a lot of benefits at the VA, like benefits from like retirement and our TSP and my ability to just save money towards my retirement is, I think, has been really great. Yeah, I guess if you wanted to do a ton of scopes, you could make more money, but again, that would not necessarily be exactly the fulfillment that maybe you would necessarily want either.
I
So,
assume I assume before your group went to the employed model, and it was, pure private practice, there probably was no such thing as paid time off, right? If you took a vacation, you stopped generating income. Is that correct?
right. And that's very true about that. Because here, since you're paid a fixed amount of money, there would be times when there'd be more and there'd be less. So you always had to kind of, make sure that you kind of kept that in mind and kept a pretty good cushion. Whereas in this model, I feel more confident that like everything's going to be taken care of. My bills are okay. Like when my daughter was in a private school, I wasn't as concerned about like, if something happened, I sort of knew and could plan what was coming in front of me. So you're right. That was a little bit of, and then I definitely wasn't quite prepared for tail insurance, which was something that came and was a sizable chunk of change at the end of my job there. So there's something satisfying about not having to kind of think about that on a regular basis, but rather put that kind of to the back of your mind.
Right. So, now that you've been through the experience, are the things you would advise residents to look at or ask about as they're looking at their first job?
Yeah, some of the things that I tell the fellows, so I mean, I guess would apply to certainly residents too, but kind of making sure that when they're going to a hospital that they kind of understand like how is this a level 1 trauma center? Is this a place that's, what are they expecting of you? How many patients are you going to be seeing on call? Is it really, are you really going to have the time that you need in your life to do the things that you want to do? Are they going to give you time to, you know, do your administrative duties? How's the shared call experience? Does everyone kind of do their fair share? What's the expectation for, one thing that did happen to us in private practice is what's your expectation for doing sort of the underserved population? Like how much of that are you going to be doing? That's another nice thing we don't have to think about at the VA. I mean, everyone is an equal opportunity person. You don't have to worry about what type of insurance someone has. Um, the tail insurance thing, I try to tell fellows, that's something that if you haven't thought about it, keep a little bit of money, stored up so that if you do decide you don't like your job or something happens, that doesn't like just come out and like whop you in the pocketbook, because it is a pretty good amount of money that you're going to have to fork over when you leave your job. The other thing is these non-compete clauses. If you want to stay in a location because your husband has a job or your wife has a job, these are things that maybe you want to consider. That's the other really, again, another nice thing about the VA is that, especially as a trainee, if you want to do something for a shorter period of time or you want to get some experience, the VA is a great place to spend a few years because you can leave and you aren't going to have a non-compete and you're not going to have tail insurance, and you're going to be able to see a lot of interesting things that maybe you wouldn't see other places. So those are some of the things that I learned definitely from private practice.
So, in evaluating a practice, are there any, or a first employed job, are there any red flags that should cause you to run screaming in the other direction? Or anything about a practice that should be, major tip-offs that this is not for you?
Yeah, I think that, when you talk to people and you can get a sense of their level of satisfaction, I think that's, if people seem generally happy and they talk to you with some degree of candor that they really are enjoying themselves. I think if there's questions about how the interaction is with the hospital or the administration, like how their employment is, I mean, you certainly want to have some control over your employment and not feel like you're being pushed in the corner to, produce too much. Because certainly we are to, we are producers, but on the other hand, we should have some flexibility. Those would be things that would be, and then the structure. Like if you're if you're sort of put at low man at the totem pole and you don't have any opportunity to sort of weigh in on your practice, I think even as a new person, you should be able to have the ability to make decisions and be a part of the group from the get-go. You shouldn't just be a worker that's like making funny money for your other colleagues. So those would be kind of red flags to me.
No, now when you joined your group, I think your group was the one with Dave Court and Mark Bernstein. Was that your group?
No, Michael Presti and
Oh,
I mean, I had a really good group. Mike and Ruben Imrich and Mobin Khan. We just had a little group and we did a lot of work.
and was it, when you first joined it, was it a partnership arrangement?
Yeah, and I was like, working to partnership like the first couple of years, and then I became a partner. And I mean, we actually had a nice working arrangement, and I felt that they were very fair, and that part was good. It was just in that time where there were a lot of medicine was changing from that, self-driven uh, group to sort of this hospital-owned way that most of the practices are now. So that was a lot of tension. And really, there was I think a big restructuring in the city of St. Louis. Lots of people moved around because different hospitals sort of owned different doctors.
So when you were looking at it, and as you say, this may be less relevant now, but I know there are some places that still have arrangements like this. As part of your progressing to partnership, when you became partner, did you have to have a buy-in for practice assets?
No, so I didn't, but there still are, and there still are some places that have, the freestanding endoscopy centers, and people put in quite a bit of money, and that was something I wasn't really interested in. It seemed like a big investment, and maybe more than I would have wanted to invest in at that time, to kind
Yeah.
of risk benefit ratio.
Is that something that that people finishing training should ask about?
I think definitely. And that was very popular when I was graduating from fellowship. I don't know if it's as popular now, just because, again, the hospitals wanted to take more control over that. The hospitals want to be able to make more money off of the endoscopies. So I feel like there was a kind of a battle between, was it doctor-owned endoscopy centers or more hospital-owned endoscopy centers? So not really sure what direction that has all taken, but I believe the hospitals have sort of pushed back on that and gotten more ownership over those freestanding centers.
So on that sort of general topic, you watched a number of changes happen in medicine. What changes do you see coming down the pike, and how do you think they might happen? How do you think that might impact on residents' decisions and what they should consider when going to practice? Do you have any thoughts about that?
Well, I think, coronavirus has changed our practice again. So I think we'll continue to do more of this virtual medicine. Um, I think physician extenders, nurse practitioners are continuing to take on the role. That was another change that I did live at least through. We did get a PA when I was in private practice, and I think that's becoming more popular in um, some private practices to be doing a lot more of the clinical work, and then the GI physician doing a lot more of the endoscopy work. Um, I hope that doesn't continue to be as much of a push, because I think that you lose your ability you want to be able to take care of patients from the clinical standpoint, not just do endoscopy. Um, So I think those would be the things that I am wondering what will happen. So what's going to happen? Are we going to continue this kind of virtual way that we're doing more medicine? Are physician assistants and nurse practitioners going to gain a bigger role in where are physicians and nurse practitioners and PAs going to wind up in the private sector? I think at the VA, we have a good working relationship. I don't know what's happening in the private sector. I think GI in general continues to just grow and grow and grow. And I think we'll just continue to become more subspecialized. So you have your general GI provider and then more specialized into IBD, liver, and then endoscopy just continues to get more subspecialized too with all this advanced, almost kind of somewhat surgical type of procedures, the like peroral myotomy. And I was just on some, it was one of the grand rounds at Washington University talking about doing basically portal pressure measurements with endoscopic ultrasound, and I was like, oh gosh, it's just like it becomes more and more intricate and intense. So I feel like the field will just continue to fraction off into these subspecialized areas.
So it's interesting. I'm going to describe an experience to you and then ask for your reaction. You were mentioning that in some practices the PAs are doing more of the clinical encounters, and the GI folks are focusing more on endoscopy. And as you know, in private practice, it doesn't make sense to have PAs do endoscopy because they can't bill for them. And so the model that you have in the VA, where you have, PAs doing routine not diagnostic, but screening colonoscopies, seems unlikely to catch on in the private sector. So I have a friend that, spent 20 years in, private practice in Connecticut, and then returned to Boston and entered into an arrangement where he was taking care of high personal wealth individuals in an academic practice. It was clearly, practicing high quality medicine, but also with an eye towards developing a donor pool. And so his practice was both in private practice and in the academic setting was high touch, lots and lots of personal attention from the doctor to the patients. He became ill with a gastrointestinal illness and was referred to a gastroenterologist. And the interaction was that his initial intake was done by a PA. He never met the gastroenterologist. The PA set him up to have an endoscopy, and he met the gastroenterologist for the first day on the day of colonoscopy. Your thoughts about that?
So I have like good and bad thoughts. I mean, good, good. There's good and bad. I really think our physician extenders, and they do a very good job, and they have a role for sure. But it's an interesting dynamic. Because that certainly has become more of the push. And it's like, I think it really depends on the complexity of the situation. There are certain things that we were trained in a different way to be able to recognize quickly. There's that gut instinct that happened to us like through all those years of taking care of people. And I just don't know that you get that. So we have a lot of we have several wonderful PAs that we work with, and I don't want to take anything away from them, but there is this certain level of, I think, necessity to maintain our autonomy and take care of our patients, especially those that are more complicated.
Right. Are there questions I should have asked you and didn't?
I don't know. I just hope the world is calm and we continue to practice medicine. And I come to the VA and I feel at least some sense of sanity. And that's a good thing, because it's still the routine and people are, generally friendly and generally appreciate what we're doing. And that's at least makes me believe that everything's going to be okay.
All right, well, thank you very much. I appreciate you taking the time to talk to me and by extension to the residents and fellows who will see this video when it's posted.